All right. And treatment of oropharyngeal cancer, TORS or not to TORS, clinical trials driving the answer. July 22nd, we have Dr. Patel and Dr. Sheth both with us. Let's find out a little bit more about each. So, Dr. Patel, welcome. Really glad to have you here today.
Yeah, thanks. It's great to be here.
And ENT otolaryngologist at the University of North Carolina, Chapel Hill, professor of head and neck surgical oncology, and received a medical degree at University of North Carolina, Chapel Hill School of Medicine. And you've been in practice for more than 20 years and experienced in head and neck oncology, transoral robotic surgery, and running clinical trials. So that's impressive. What's one other thing we might know about you outside of your professional realm?
I like to run a lot. I
You
think
like you're a runner?
yeah, I like to run. It just keeps me level-headed, I think. Gets all the nervous energy out.
Good for you. All right. Well, thank you so much. Really glad to have you here. Dr. Sheth, um, DO, MPH, medical oncologist and associate professor of medicine at the University of North Carolina, specializing in head and neck cancers and thyroid malignancies. Serves as co-leader of UNC's head and neck cancer program and directs a broad portfolio of clinical and translational research focused on developing new treatments and improving outcomes for patients with cancer. His work on innovative immunotherapy approaches, early phase clinical trials, and precision medicine strategies that use biomarkers such as circulating tumor DNA to personalize care. Dr. Sheth, remind me where you got your DO.
I was in Lake Erie College of Medicine in Pennsylvania.
Excellent. And what's something that we should know about you outside of your professional bio there?
Yeah, I like to think of this as my side job. I have two young boys, and they rule my world.
Gotcha. Gotcha. Really glad to have you both here. Here's that first poll everywhere question. Uh, this one's always a softball. We just get everyone through the process of using this. So, transoral robotic surgery or TORS lets the surgeon work in areas of the mouth and throat that can be hard to reach or hard to see with other kinds of surgery. And we'll let that run a few more seconds, but we seem to be trending pretty heavily on the true. Doing all right there? Yeah, all right. So we've got a nod of approval on this. With treatment of oropharyngeal cancer, I'll turn it over to both of you. I believe Dr. Sheth, you're kicking things off.
Yeah, so it's a real pleasure to be here, and I'm especially honored to do this with Dr. Patel. We co-lead the head and neck program at UNC, and we're going to be talking about a really important area for the field of head and neck cancer, and have a number of slides to go through, but we hope that it will be informative as we get to the end of the talk. And so here are disclosures. And so just to give a background about head and neck cancer, this is a very heterogeneous cancer. It consists of many different anatomical sites that come together. Primarily, we see this cancer originating in the oral cavity, the oropharynx, the larynx, and then there's also some smaller anatomical sites that are also included. Our primary focus is going to be the oropharynx, and within the oropharynx, there are a number of subsites where we see this cancer in the soft palate, the palatine tonsils, the base of the tongue, vallicula, and the posterior pharyngeal wall. The two primary locations, though, are within the tonsil and the base of the tongue. And so we know that there are two major kind of drivers or risk factors for this cancer. One is, and that's really subdivided by the human papillomavirus, so whether it's associated or unassociated. And traditionally for head and neck cancers, this was an HPV negative uh, tumor that was driven by tobacco and alcohol. Unfortunately, even in 2026, we know that patients who have an HPV negative head and neck cancer's prognosis is poor. And now we know over the past 2 to 3 decades that there is an HPV associated risk factor. And so we use a surrogate um, biomarker called P16 that you might have heard of. And what we know from a lot of clinical trial data over the last few decades is that this is actually a good prognostic factor to have. The biology is more favorable. And we also know that from an epidemiological standpoint, these patients tend to be younger, they tend to be healthier. And so when we think about HPV, it's really exploded in what we're seeing in North America. And specifically, this cancer focuses on the oropharynx subsite. When we think about head and neck cancers, we know that now it accounts for about 70 to 80% of all new oropharynx cancers. There are over 100 different subtypes of the human papillomavirus, but HPV 16 and 18 are the most common, with HPV 16 being the most majority of the cases. As I mentioned before, these patients tend to be male. They tend to be about a decade or two younger than the HPV negative patients, so in their fifth and sixth decade. And importantly, when we're talking to patients, we're at least able to say, well, it's unfortunate that they have a cancer diagnosis, that their overall survival is very excellent for this specific subtype of HPV-driven disease. And we know that patients have about an 80 to 90% um, chance of being alive at the 3-year mark. And with our improvement in therapeutics and as the field is changing, we hope to get to even a higher level. And so because we know prognosis is excellent for this patient population, there have been many efforts to give less treatment while trying to preserve overall survival and then helping to improve with toxicities and long-term survivorship. And so, one very interesting factor about HPV is that it can affect many different parts of the body, including gynecologic sites like the cervix. It can cause anal cancers. It can also cause head and neck cancers. And what has been quite fascinating about the biology and the epidemiology of HPV-driven cancers is that in just the past 5 years, we've seen where cervical cancer was the most common site for where HPV cancers originated. Now the oropharynx is number one. We also know that as the numbers go up over the years, about 50,000 cases are HPV associated. So it's just this massive increase in the incidence. And so from a public health perspective, it's also very important that we are thinking about how to have effective treatment and prevention strategies. And so, talking specifically a little bit more about HPV-driven head and neck squamous cell carcinoma, we've seen even in the last 20 years that there's been an increase in incidence from 10,000 to about 16,000 cases that will be projected for 2030. As I mentioned before, about 70 to 80% of these cancers are HPV driven. And just even in Europe, for example, we've seen that the number of cases have quadrupled. And as I mentioned before, this is the most common site for an HPV-driven cancer. So again, key takeaways, if you're going to think about it from an epidemiologic standpoint, it's a rapidly growing disease, and we really need to come up with even better treatment strategies. All right, so when we think about how we treat head and neck cancers in 2026, there's still not a clear distinction from an HPV associated and HPV negative cancer in terms of when we're thinking about treatment in the curative intent stage or status. And so one of the major ways we treat it is with a combination of chemotherapy and radiation therapy. This is historically because of the location of these cancers. Doing surgery with a more open approach can be morbid, and there can be complications from that. So a non-surgical approach has been favored by many centers, including UNC, over the past decade. And so the approach was a combination of radiation therapy, 7 weeks, a 70 gray total, in combination with a chemotherapy called cisplatin that can be given weekly or over an every 3 week dosing strategy. And so, I think in this kind of example here, we can see a patient who is diagnosed at a young age, and so we feel really good about curing them. But the other thing that happens is the survivorship aspect of their journey, and so these patients are at higher risk of having a second primary head and neck cancer. They can have vascular disease. We can see that their immune system is less functional after treatment. And there's been very good data that after you hit a certain threshold of radiation therapy, it can lead to changes in the musculature that can lead to increase in swallowing difficulty. And so long-term survivorship issues for patients with this cancer treated at this high dose is difficulty with swallowing and dry mouth, which is a really kind of challenge as they get um, past their treatment and can cause other health issues that are just challenging to deal with. And so there have been many studies that have been done over the years to say, what can we do from the current standard of care, which is that 70 gray of radiation therapy and the weekly cisplatin, and can we de-escalate? Can we give less therapy? Can we give a different type of therapy to help patients maybe have a better functional outcome from their treatment, and then in terms of their long-term survivorship? So RTOG 1016 was a cooperative group trial. So this was a large trial done at many centers across the country. And it asked the question, could we replace the type of systemic therapy rather than doing cisplatin? Can we use something called cetuximab? This is a targeted therapy. It targets a pathway called EGFR. And it really focused in patients with, again, HPV-driven oropharynx squamous cell carcinoma. And so, I think to the surprise of investigators on the study and to the field was that, unfortunately, cetuximab uh, did not improve overall survival. In fact, it led to a numerical a decrease in overall survival at 5 years, 84.6% versus 78%. When you look at the hazard ratio, it was actually worse with a p-value of less than 0.02. And so, again, it was not only not inferior, it was inferior to cisplatin. And so even while there may be a biological rationale to think a drug like cisplatin could be effective in this population, what we learned from this very large trial is that cisplatin remains the standard of care chemotherapy that we pair with radiation therapy for HPV-driven oropharynx cancers. And so, this study has, or this concept using cetuximab to replace cisplatin has been replicated in multiple large studies. I talked about RTOG 1016. There's also a large study that was done in Europe called de-escalate. It had similar findings. Using cetuximab was inferior to cisplatin. It had lower overall survival rates. The recurrence rates you can see in this middle column here was 16% versus 6% at 2 years. And the other piece too, why did people think that cetuximab could be good is that perhaps it had a less toxic side effect profile. And what we showed, or what these studies showed, was that cetuximab, when combined with radiation, was not even less toxic. And then finally, there was this TROG study that was done in Australia and New Zealand. Again, showed that using cetuximab was not equivalent to cisplatin. So we have three very large trials that showed that cisplatin and radiation therapy is superior to cetuximab and radiation therapy. It doesn't change the risk profile or the adverse events. And so when we have these patients come to see us in clinic, cisplatin remains the chemotherapy of choice. Um, Another large study that was done was NRG Head Neck 002. And this asked a question of, again, in patients with HPV related or P16 positive disease who were kind of on the low to intermediate risk and didn't have large or long smoking histories. could we drop the cisplatin and just give radiation therapy? So it was a two-arm study, radiation plus cisplatin versus radiation alone. And so again, what this study showed was that radiation alone was not sufficient, and the addition of cisplatin to radiation therapy helped improve long-term outcomes. And so again, we by trying to give less therapy, outcomes were compromised, and so the takeaway from this study is that radiation alone is insufficient, even for kind of the good lower risk HPV-associated oropharynx cancer, and that if you continue to use cisplatin, it can help achieve really good disease control and give good quality of life. Now, let's see here. And then finally, there was a more recent study that looked at, and it was called NRG Head Neck 005, and it asked another question. So we know cisplatin works, we know radiation works, but can we give a lower dose of the radiation therapy with the idea of can we have less long-term toxicity and can we still preserve good overall survival? And again, this was based on a lot of work that was done at UNC, other places where it was thought that a lower dose of radiation therapy at 60 gray could have equivalent outcomes. And much to the field's surprise, patients who got that 70 gray plus cisplatin, so the bigger dose, the longer treatment, they had really excellent long-term outcomes. You can see here on this box on the left that the progression-free survival was 98%. And so that was just in a really high bar to beat. And so now we sit in 2026 where there's been this tremendous effort to try to de-escalate therapy. And still what we've found is that radiation plus chemotherapy with cisplatin at the high dose is remains kind of the key and the best to get outcomes. So I'm going to pass it over to Dr. Patel.
Thanks, Dr. Sheth. So when we think of that, he just laid the framework of current management and treatment at that time. So take that back to around late 2008 to about 2015. And in the meantime, surgeons were trying to determine if there were other avenues in treating these patients, given the toxicities that were seen. And in the midst of all that, what evolved was the clearance of transoral robotic surgery. So this is a picture of me where when fellowship at the University of Pennsylvania, where this whole process and procedure was invented. And in the meantime, to get a device approved for treatment, you essentially have to show it's safe. And so that's what was done through this study. And patients did pretty well. And the question is how well after the device was cleared and the to use for treatment, the question was how do we manage or compare the toxicities between the two forms of treatment. So chemoradiation or radiation toxicity there on the left versus surgical toxicity on the right. And as you can imagine, it's very difficult to do that except for hypothetically. And that's where these arguments would go back and forth when we discuss them in treatment. And it's really just points of contention. And and you can see the list of things that are there that are common in the forms of treatment at that time. And I will say that a lot of these are really are not as severe any further because of how treatment has changed in some ways, which we'll get to.
So just like any cancer in this day and age, we really think of the management of our patients with head and neck cancer, taking it from a multi-D approach. And so uh, there are critical team members across the spectrum. And so it's not just the surgeon or the radiation oncologist or the medical oncologist. It is also our nursing team. I think when we think of patients who are getting surgery or chemoradiation therapy, they're the ones that are helping assess the airway, monitoring for bleeding, helping with trach care. our nursing teams are important for looking at, say, radiation-associated mucositis, so how patients are doing from within their mouth and how to help manage their pain or swallowing difficulties. They help us with if they need assistance for nutrition with a feeding tube and how to optimize their nutrition. Uh, there are acute and long-term complications with swallowing issues, so monitoring for dysphagia and how to help patients gain their swallowing function back over time. Our nursing colleagues are critical for patient education, so whether it's helping them understand, patients understand what is the treatment journey going to look like and what they can expect from a side effect profile um, or what a day-to-day operations look like, helping them to identify side effects that may happen on the course of their treatment. And then there's just this whole huge field of survivorship, which we've alluded to. So it's dry mouth and intermittent swelling in the neck with lymphedema, or just the um, the burden, not only physically, but the emotional burden of this treatment and how daunting it could be. And so providing that psychosocial support. Another critical team member is our pharmacy team. And so, as I reviewed previously, cisplatin, while it's an effective drug, it comes with a lot of toxicities. It can hurt the kidneys, it can cause neuropathy, it can change a patient's ability to hear, causing ringing in the ears. So, there's a very protocolized manner for how we treat and treat patients who are actively getting cisplatin. We look at their kidney function over time. If there are big changes, we may have to hold the treatment or go down on the dose. So our pharmacy colleagues are critical for that. Another big side effect is anti-nausea things like medications. And so giving Zofran or Compazine or giving steroids to help with nausea and vomiting. We know with cetuximab, one of the major complications is rash. So can we give antibiotics or steroids to help manage with that? As we're moving into this era of immune therapy, there are rare but real complications with immune-related adverse events. So our pharmacists are very instrumental with helping to manage these RRAEs by giving, we can give steroids to help with managing a flare and helping them to get back on their treatment. And then finally, the radiation oncology field is quite complex. And so there are physicists and dosimetrists and other key staff members that make sure that a patient is getting the right treatment plan through the simulation. They help with kind of daily monitoring to make sure that the volumes are correct. We rely on imaging modalities quite a bit to look at from diagnostic standpoints, to look at treatment effects, to see if the cancer is recurring using CT scans and PETs. And so this is a dynamic process and a very complex care team that is required to help a single patient get through their entire journey. And as we say here in the bottom, each member has a distinct and irreplaceable role, and it's paramount that we're all functioning as a team, using good communication to really help the patient have the most success of good long-term outcomes. And so one important factor that we think about is something called extranodal extension. And so, we all have lymph nodes all over our body. One of the most common sites that a head and neck cancer can metastasize to is the cervical lymph nodes. And so what we know is that patients that have something called, again, ENE or extranodal extension, where the cancer goes into the lymph node and then escapes into the capsule that's surrounding the lymph nodes, that is a risk factor for disease recurrence. And so when we see that pathologically, so after surgery, we often escalate or give more treatment because of the high risk for recurrence. And then we're also kind of noticing, or we can detect ENE on imaging. And so, there are radiographic or imaging features that can be helpful to detect E&E. It can be the size of the tumor. We can see necrosis. We can see stranding or different kind of the contouring of the node. We can sometimes see that the cancer really is getting into the capsule just from imaging itself, or there's a matted or conglomerate appearance of the lymph nodes. And so what we've kind of found is that using imaging alone to detect A&E can be challenging. And I won't go through all this data here, but basically what we found is that imaging to detect extranodal extension, while it can be effective, it can also miss a lot of these cases. And so it is something that we use in conjunction, but not alone is imaging sufficient to detect extranodal extension as we go later on into this talk. The other important thing to highlight is that over the years, there have been updates to how we stage head and neck cancers. We use the American Joint Commission on Cancer. In 2019, it came out with the eighth edition, and it really made this distinction of an HPV-driven and an HPV-negative cancer. Again, looking at prognosis, it showed that these cancers overall have more favorable prognosis. And so one of the major changes is that a diagnosis of a locally advanced or curable HPV-driven cancer only goes from stage 1 to 3. And so that was a change from HPV-negative cancers. Stage 4 really involves when you have metastatic disease where it's gone out of the head neck region and out of the lymph nodes. And that's in distinction again on the right where you see HPV negative cancers. And this is specifically for the oropharynx, where you can still have a stage 4A or stage 4B cancer that is technically curable. And so what AJCC 8th edition helped us redefine was just even you can have a more aggressive appearing cancer, but it's downstage into stage 1 through 3. And then more recently, over the last year, there's now the 9th edition. It just got incorporated on January 1st of 2026. And so this made a major update of taking into account two additional factors. So we've talked about extranodal extension, but the other kind of major factor is looking at the number of lymph nodes that are involved pathologically. And so the change that it made was that you could have N2 disease, which involved either having greater than 4 lymph nodes involved or extranodal extension. And then if you have both of those factors, that upstages you to N3. And so what this means more practically is that based on the classification, that is kind of a higher risk. If you go up on the staging, your risk of recurrence goes up, and that has ramifications for how we treat these cancers. Okay. And then here, just kind of thinking a little bit about uh, our staging and then how we're coding these patients. A very busy slide. I think one of the major points to highlight here is that this new AJCC 9th edition really highlights the importance of documenting extranodal extension. And so that status of whether it's positive or negative is going to be instrumental for the final pathology. So if it's negative and then you have those positive nodes, it could be N2. If it's both of those are positive, like I said, it could be N3. And so this is that change from the 8th edition to the 9th edition. Another kind of factor as we're getting more modernized into artificial intelligence and having AI help us with our imaging technologies is just to on a CT scan, can we use AI to help identify E&E? And so there have been some studies that have looked at comparing artificial intelligence versus just the conventional radiologist looking at it. And what's been pretty fascinating is that when you put the two side by side, artificial intelligence has actually been able to outperform a radiologist in determining if a patient on their imaging has extranodal extension. And so as we're getting more savvy with our technology, we can see that AI will be very helpful to have the correct diagnosis, to have the correct staging for our patients. And again, that's going to be very critical for then how we treat our patients. Um, and then this was just a specific study, the 3311 trial, the ECOG-ACRIN, that looked at, again, this question of, is artificial intelligence as good as radiologists in terms of helping from a diagnostic standpoint and in terms of identifying imaging associated extranodal extension? And the long story short was that yes, AI was better. They had really high quality radiologists that were part of this study, and time after time, AI was able to help find E&E that humans were either missing because it was just too small to see to the naked eye. And so this is something that we as a field need to embrace and hopefully help to incorporate into our practices moving forward. We just have this poll the audience question.
So according to several studies, AI consistently outperforms radiologists across all metrics. Thanks for the quick responses. Dr. Patel, Dr. Sheth, how are they doing?
Yeah, I mean, I think it's interesting to see the 50-50 split. There are definitely metrics where AI outperforms a radiologist. Probably not the best worded question. I would say in all metrics, that's probably false. I don't know, Dr. Patel, if you want to add anything else.
Yeah, I mean, I think there's a lot that gets incorporated into the clinical aspect, but when you look at it from a sensitivity and specificity aspect specifically, it does outperform. And that gets us to really the crux of the matter that we alluded to previously with prior trials. How do we de-escalate these patients? They're younger. They have more years to live with the side effects of radiation therapy, which also include the possibility of developing a second primary. And all of this is discussed with them at the time. The challenge is that the dose that is delivered and is received and lived with for 20 plus years, we didn't typically see that in radiation oncology. And so as a way to consider what options patients might have, we thought now that TORS is an option for treatment, is there a way to de-escalate therapy? And we do that after surgery in general, where we lower the dose. Is there a way we could do that for this patient population? So this trial was really developed by Dr. Bob Ferris, who is the director of Lineberger Comprehensive Cancer Center, and is actually inspired me to go into trial work. And what was done essentially is that the lower risk population, or the patients that were eligible for surgery, so the smaller tumors that you can see classified there, were then go through surgery and based on pathology divided into these separate arms, A, B, C, and D. Long story short, the patients that were randomized between B and C, where you would lower the dose to 50 gray, those patients did extremely well. You can see the progression-free survival being at 95% for that group, which equaled the 60 gray group. So in a phase 2 study, this has really been the only trial so far to show that we can de-escalate from a cooperative group setting. And the importance of that is that when you look at that, that started changing how patients were treated to some degree. And that's why this whole idea of extranodal extension became a process and a conundrum. We can't really predict those patients preoperatively. So are we over treating patients who get chemotherapy after surgery in addition to the radiation? And so these were again a number of the points of contention that we talked about. And when we looked at the swallowing outcomes for these patients, they also did very well with very few patients needing G tubes afterwards. And so after looking at the complete picture, we are seeing that it's really been beneficial to add this as a paradigm for patients. The question is upfront, how do we decide and what can we do? And so other independent groups started opening trials looking at other ways to de-escalate, including using uh, chemotherapy before surgery to see if that was potentially an option, or using it with all patients after surgery. And so in this case, patients were receiving a lower dose of radiation along with chemotherapy for every patient, essentially. And so lower doses of chemotherapy, lower doses of radiation, but using all of our uh, expertise to try and find a way to maximize patient outcome. And you can see that by shortening the doses of radiation or lowering the dose of radiation, you shorten treatment time dramatically. And that also allowed for patients to get back to work sooner, but without compromising the local regional control. If you look at the 2-year efficacy rate there, you're still talking progression-free survival and overall survival above 90%, which then started creating other trial designs. And what are the most effective ways to treat patients now that you're minimizing the toxicities from all these other treatments? Because we've lowered, it's just now when I think about it, it's a little bit of surgery, a little bit of radiation, a little bit of chemotherapy, and with a good result. So this starts creating more thoughts around how do we manage these patients. But meanwhile, the standard of care again was 60 gray or 70 gray in cisplatin versus surgery and risk adapted treatment based on pathology. And that's when this trial became available and was run in Canada. The Ordo trial was the first trial to be able to compare head to head chemoradiation therapy versus surgery. And so really quite remarkable to be able to randomize patients between these two options. Most patients are pretty opinionated about their treatment options when you tell them that the progression-free survival or overall survival are about the same. So the fact that they were able to do this really was in part because of the way their healthcare system is set up. And because TORS was not a standard, you randomized into TORS. And I think that's why patients were willing to move forward with this process. So the interesting thing here is the key finding is that overall survival really comparable between the two. And the initial signal was that swallowing outcomes were worse in the non-surgical treatment, but then that started to uh, flatten out and converge over time. So very interesting as time progressed. And when this trial presented, a smaller trial because it was based on an endpoint of swallow function. So real only about 70 to 80 patients on trial. Uh, Truly not enough to give a signal, but I think again, very impressive that they got it this time. Two, after the first readout, there was a very as you can imagine, there was a shift in how patients were treated or surgery worthwhile or not, and created some uh, very interesting debates for sure, particularly when you look at how swallow is assessed. So the MDADI, which is what the Orator trial used, is a subjective, validated assessment of swallow. It has 10 questions, and that's how it's used. This is an objective swallow measure using modified barium swallow studies, which we do with our speech and language pathologist, and digest scores. Again, looking at how the pharyngeal or the swallow function is working. So is the base of tongue pushing back? Is the hyoid bone moving up? Is there a retraction? Is there what they call pharyngeal squeeze? And so we did and studied this to look at how patients did after robotic surgery to see what their swallow function would be like. And really the only thing that separated patients out were older patients did not do as well with their swallow function based on these objective measures. And what was also very interesting is that these smaller tumors or these unknown primaries, which we often see, many of these patients present with a large lymph node in the neck and a very, very small tumor that we can't even often see when we are examining the patient or on imaging, PET or CT, that for that matter. All the patients treated using what we call our unknown primary paradigm or protocol have amazing swallow functions because makes sense. The tumors are smaller and less tissue is removed. And now, for the most part, this has informed us on how we can further de-escalate treatment. When you add all these imaging modalities and everything that's been done to try and figure this out, you notice that it's very difficult to find and identify these tumors. But the way we do that and the way we can help with that is using surgery. And so before we get to that, according to several studies, we have patients swallow better after chemoradiation therapy compared to TORS.
All right, Dr. Patel, how are they doing?
Oh, I think they did excellent. Yeah, no, it is. They're just different parts of it, and it just, all in all, uh, it's just one thing that doesn't work well in one form of treatment, works pretty well in the other form, but there's something else that doesn't work well in the other form of treatment. So all in all, they basically equal out between the two. This is an example of how we find unknown primaries in the clinic using a special blue and green light. And you can see here, this is small tumor looking if you're looking at this picture of the base of tongue, this blue-green light has identified this circled stippled area. It's about 3 or 4 millimeter tumor. So when we use transoral robotic surgery, we can actually de-escalate therapy because we're finding the very small tumor, and what that does is it allows us to decrease or potentially eliminate volume of radiation therapy to the tonsil, to the tongue base, to the throat. Whereas in previous iterations of treatment for unknown primaries, the entire pharyngeal axis was being radiated. So basically, I'll go through this quickly here, is where the FIND trial that was performed in Canada noted that primary tumors were identified 72% of the time with exactly what we were just talking about, a significant reduction in grade 3 and 4 toxicity, and with excellent local regional control. And so we're able to de-escalate. And so we do this here as well, where we take the tonsil. This is an example of that. We take it to pathology in real time. We look for the tumor. And if we find it, then we make sure we clear the margins and then move on to the neck dissection. This is just an example of what that looks like and differences with the radiation therapy, with the red being the higher dose, and you can look at the ISO doses there and the lines on the left versus the right. When you spare radiation to the primary site, then you decrease the toxicity. There's radiation that gets there, but what you can see here in this slide is that most of the patients we treated when we did this were small tumors, and most of them had one or fewer than 4 nodes. And what you more importantly see is that we know all of them, for the most part, are going to need radiation because they presented as unknown primaries, but the number of patients that were spared treatment to the oropharynx, 60%, and even more importantly, the volume was cut down to half the neck versus both necks. And that's because there was a tonsil primary as opposed to a base of tongue primary. But all in all, this was also studied at Penn, looking at how can we avoid treatment to the pharynx if we have appropriate margins, and they used greater than 2 or greater millimeter margins. And notice again, high local control rates, excellent overall survival with a lower dose to the constrictors. And that what that does is that the swelling function is even better. These patients do better with lower doses. And ultimately, these are the trials that have tried to de-escalate, as you can see, but the only one that has been able to so far has been 3311, thanks to Dr. Ferris. So this is one of the reasons why it works, and we're able to just get more information. Sometimes more information is better, and with surgery, we're able to get pathologic information. But now there's some new technology that's coming on board that is, in my thought process, maybe potentially better than pathology.
Yeah, so we hope at this point you've seen that TORS can be a very effective treatment strategy for this patient population. And here comes the fun part in the innovation. What can we do next to further the field? And we're going to really quickly go through two treatment modalities that are gonna, we think, can help move the needle even further. First is something called circulating tumor DNA. And so basically all cells are made out of DNA. Similarly, our cancer cells are made out of their own distinct DNA. Specific to an HPV-driven cancer, this is driven by its own viral DNA, these E6, E7 proteins. And what has been really, really fascinating is that we can now detect CT HPV specific DNA within the blood. And there are these different assays that allow us to do that. Many companies, you can see on the right, there are commercial assays which have really honed in on being very specific to not only identifying cT-HPV DNA, but specific subtypes like 16, 18, 31, etc., the high-risk HPV subtypes that can cause oropharynx cancers. And what we've found in time and time again is that these are very sensitive and specific studies. You can see that there's a very high 99% negative predictive value using cT-HPV DNA. You can also see that there's lead time. So cT-HPV DNA can help us identify that there may be molecular disease before we can see it either on a clinical exam or with imaging. And and so these are really powerful tools that are now helping to guide how we surveil and look at treatment response. And so what's been really exciting for the field is that there are different pieces of the treatment journey where we can see that CT, HPV DNA, and even larger CT DNA can be used. It can help to look at response to chemotherapy prior to surgery or radiation therapy. So patients that are able to clear their ctDNA levels from the starting of the chemo to at the end tend to do better. We can look at kinetics during radiation therapy. So patients that clear their CT HPV DNA tend to do better. If you can see the clearance midway through radiation therapy and obviously at the end of the radiation therapy, we can see patients that have surgery. And if they don't have what we call molecular residual disease or MRD using CT HPV DNA, they tend to do better long term. And so this is a really powerful biomarker to help assess treatment response and to look for things like treatment recurrence after a patient has completed their treatment. And there's a growing number of areas where ctDNA is adding value. So surveillance, looking at response to therapy, and then in the post-surgical minimal residual disease setting. Um, this is a very active area of research. There are a number of fantastic studies that are going on currently trying to assess how ctDNA can be incorporated. And I know we're kind of getting short on time, so I'm going to move a little bit forward where I want to talk about that second strategy of trying to use something called induction or neoadjuvant chemotherapy prior to TORS. And so this is the idea of, can we give chemotherapy before we do surgery, with the idea of shrinking the tumor to helping to achieve better treatment control, to help our surgical colleagues have more success with their operative plan. And so this was a study done at the University of Chicago that looked at incorporating induction chemotherapy with immune therapy, so giving treatment prior to surgery or radiation therapy. And what it found was that patients who had a response to induction therapy and had clearance of their ctDNA, that predicted that they did better over a long period of time. So putting the two together, if you're a responder to systemic therapy, and if you can clear the ctDNA, that is, we think, a powerful match to help predict which patients might do better over time. It also tells us about disease biology, and it can help us then determine what is a good way to maybe give less treatment if we see more favorable outcomes to both induction therapy and ctDNA clearance. Um, I'll spend 1 second talking about the NECTORS trial. This was just a study in patients who had HPV-associated disease. They got induction chemotherapy. And what it found is that those who got this treatment and then went on to TORS, all these patients were successfully able to omit radiation therapy after surgery. And so we started this conversation talking about how can we help patients have better long-term survivorship. And so this is a very positive step into reducing a very morbid treatment such as radiation therapy. And then I'm going ahead just in the interest of time. Tim, I hope you don't mind, but I want to let Dr. Patel finish out our last few slides talking about TORS in a trial that we have proposed to help move the field forward.
Thanks. And so I'll just go straight to the trial, which is we are in the process of opening this trial, hopefully to help our patients in the state of North Carolina essentially get uh, treatment and take advantage of all the things that Dr. Sheth just spoke about. So we're going to take technology and use ctDNA. We're going to use uh, neoadjuvant chemotherapy along with immunotherapy as a way of doing that and reducing the tumor. But when we offer surgery, the plan is to do a reduced level of surgery. Now, if some patients get an incredible response, which you can see here, if you just go to the top level where it says they have where it says yes, we're going to check their ctDNA levels. And if there's no more tumor seen in the blood, and we do that on two separate occasions, we're going to observe those patients, at least not give them surgery, but to have them continue immunotherapy for the next year and continue with blood tests along that time point. Now, if a patient were to convert to being positive, they would have a simplified surgery. And our goal here is to minimize the morbidity of disease and start using and incorporating these smarter drugs that are allowing us to potentially take advantage of how patients develop these cancers, specifically with the viral driven form. And so that's really an exciting thing for us, and that we're excited to offer as a potential for patients in general. But I think what we know, and I'll just get to the summary, is that really the problem is when we think about transoral robotics is just one, you want to go to a place that where a lot of this is done because of how the lesion and how we know that we can have the margins be much tighter. Local control rate's very high. Failures usually in the neck or distant. And so we've noticed that these extranodal extension does matter because it may predict a worse biology for whatever reason and mutational burdens that may confer. Trying to figure that out and doing that proactively with AI is ideal, but it's not standard. And then really just what can we do to optimize patients in an innovative way? And I think that's where we're thinking about neoadjuvant chemotherapy and immunotherapy to possibly change the paradigm even further.
Yeah, so I'll just end that if I can put Dr. Patel and the radiation doctors out of a job, I think it'll be great for our patients and maybe for um, helping them with their long-term outcomes and survivorship. And so we want to thank everyone for their time and attention. Happy to take questions.
All right. So I'm checking to see if we have any questions and it looks like none have been submitted. We have just a couple of minutes for questions. So pollab.com/UNCLCN. Hopefully we'll get a couple before we run out of time. Whoops, sorry, we just shifted away. That was my fault. There we go. While we're waiting, I was curious when you looked at the AI results for around the imaging. I thought that was fascinating how much better the AI appeared to perform. Were there any situations where the AI didn't perform as well, even though it was overall statistically better, or was it across the board?
From the studies that I looked at, it's fairly consistent across the board.
Okay,
And as you can imagine, it just happens to, you know, the number of scans that can be put through an algorithm are much more than one radiologist could ever see.
uh-huh.
And then the difference also is that the algorithm, they also know the outcome. So you're not just seeing the scans, but you know the outcome that happened with the patient.
Right.
So you're seeing the pre and the post treatment and then combining it and then looking for factors that allows for that decision making to be made. And that just doesn't always happen. Yeah.
Gotcha. Thank you. I'm going to go ahead and skip ahead a little bit and then come back in about a minute to see if we have any more questions submitted. I know that folks need to get on with their days, as do both of you. So we did have one question about the how to claim credit for the webinar, and our staff will reach out to that individual and let them know separately. So we do want to say thank you. Thank you to the state of North Carolina, the support of the Lineberger Comprehensive Cancer Center. Thank you to the team. Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Kim Riddick. We appreciate all the hard work each and every one of them does.